please.
Thank you, Mr. Chairman. Dear Professor and colleagues, it is my extreme honor today to present to you the results of this study aiming to compare the difference in advantages provided by a laparoscopic approach for anterolateral and posterior superior resections of the liver. The central element that has promoted the dissemination of laparoscopic liver resections is the associated clinical benefits for patients documented in a plethora of studies comparing with the traditional open technique, initially for anterolateral and more recently for posterior superior resections. However, the degree of advantage provided by the minimal invasive approach has never been measured, quantified, and neither compared directly between liver resections carried out in different topographies and hence characterized by different kind of complexity from the technical point of view. As such, the aim of our study was to test the hypothesis that the magnitude of benefit provided by a laparoscopic approach may be different for anterolateral and posterior superior resections, with the ultimate goal to identify the pool of patients that benefits most of the minimal invasiveness. The data for this study were extrapolated from our institutional database that at present accounts for 2,800 liver resections. More than 900 with the approach by the laparoscopic technique and the rest with the traditional open approach. The exclusion criteria for this study were major liver resections and associated major abdominal surgery to the liver resection itself. Also, the time frame for this study was restricted to the year 2011 onwards, when an enhanced recovery protocol for the perioperative management of all liver resections was systematically employed at our center. The aim of the study were pursued through a two-step process. The first step was to verify the efficacy of the minimal invasive approach with respect to the open technique. So the entire cohort of liver resection was subdivided into an anterolateral and posterior superior cohorts depending on the topography of the liver resection, and each of these two cohorts was further subdivided in two groups, named laparoscopic and open accordingly to the technique used for the liver resections. Laparoscopic and open patients within each cohort were compared as for what concerns a number of clinically relevant parameters, and the difference for each parameter was computed as mean or median difference for categorical and continuous variable respectively, and named anterolateral and posterior superior differences respectively. The second step of the process was to quantify the degree of advantage provided by laparoscopy and to compare it between the anterolateral and posterior superior segments cohort. So the anterolateral and posterior superior differences previously computed were compared, and the degree of advantage was expressed as the delta between those two differences and named delta of difference. 1,004 liver resections were totally enrolled in the study. Before the comparison, matched pairs of laparoscopic and open cases were selected via a propensity score matching in order to adjust for possible confounders related to the potential treatment selection bias. The matching covariates included the main acknowledged confounders of the choice of the technique for the liver resection, so laparoscopic or open, and the potential determinants of the postoperative outcomes. The matching goodness was verified at the end of the process and was judged adequate since all the covariates showed a standardized mean difference below 0.25 as shown by those histograms with overlaid kernel density estimates. Also, the matching goodness was verified through univariable and multivariable tests for residual global imbalance, which ended not significant at the end of the matching process. The comparison between open and laparoscopic cases within the anterolateral segment cohort of resection showed that laparoscopic cases are associated with a benefit in terms of blood loss, total morbidity rate, time to orally controlled pain, time to independent mobilization, and total stay. The comparison between open and laparoscopic cases within the posterior superior segments cohort replicated those advantages, but also showed that laparoscopic cases have a benefit also in terms of red blood cells transfusion rate, minor morbidity rate, and time to functional recovery. The following charts and table depict the difference in the degree of advantage between anterolateral and posterior superior resection as for what concerns all the parameters identified, that is, the delta of difference. Posterior superior resection showed a larger degree of advantage in terms of blood loss when compared to anterolateral resections, and it is likely that the pneumoperitoneal pressure established during laparoscopy turns out to be more beneficial for posterior superior resection than anterolateral, since those are usually characterized by a higher amount of blood loss. And this is a hemostatic factor totally absent in open surgery. This likely justifies also the larger degree of advantage shown for posterior superior resections, also in terms of red blood cells transfusion rate. The delta of difference was also significant as for what concerns the total morbidity rate and the grade 1 and 2 morbidity rates, since posterior superior resection showed a larger degree of advantage compared with anterolateral resection, whereas the major morbidity, 30 days mortality, readmission, and R0 resection rates were comparable in terms of delta difference between the two cohorts. The significant degree of difference in terms of morbidity likely justifies and gives reason for the larger degree of advantage shown by posterior superior resections in terms of time to functional recovery when compared to anterolateral, which likely is also influenced by the larger degree of advantage in terms of time to orally controlled pain. In fact, posterior superior resections approached by laparoscopy avoid an intense and prolonged retraction of the abdominal wall that is necessary in open surgery to get access to the dorsal area of the liver and complete the mobilization phase that is seldom necessary when an anterolateral resection is conducted by the open approach. Finally, our study also shows and corroborates that the posterior superior laparoscopic resections are complex procedure exhibited by this graph in terms of a larger operative time and Pringle maneuver duration when compared to anterolateral resections. In conclusion, while both result in beneficial when compared to open, the advantages of laparoscopy appear greater for posterior superior than anterolateral resections despite their technical difficulty. Feasibility, safety, and efficacy of laparoscopic liver resection acquired, the interest should now be focused on fine-tuning the knowledge of the advantages for selected procedures and in specific settings. Also, our study shows that there is an actual advantage that a minimally invasive approach can add to the systematic adoption of an enhanced recovery protocol. And this is of particular interest in the current era, where the differences between minimally invasive and open techniques in terms of outcomes are supposed to be partly flattened by the application of fast-track protocols. We believe that hepatobiliary surgeons and centers providing their services in the contemporary era should consider a progressive implementation of minimally invasive techniques for liver resection and to develop a stepwise expertise that leads to encompass increasingly challenging laparoscopic procedures without stopping in the safety area of the easiest resections. Accordingly, the modern training programs should aim to develop the most comprehensive individual proficiencies so as to allow the accomplishment of a full range of procedure. And in parallel, collective efforts should support a confident expansion of candidates to laparoscopic liver resection within the activity of hepatobiliary units in order to establish surgical programs of the greatest clinical value. Thank you for your attention.
Thank you so much, Dr. Cipriani. This excellent paper will be discussed by Professor James Garding from United Kingdom.
Chairman, thank you very much for the opportunity to discuss this paper. I'll start off just by making the observation that I'm really pleased that we have a representative of the IHBBA Women in Surgery presenting in the best of the best. There are actually an increasing number of studies being undertaken currently to review databases retrospectively, and I'm obviously pleased that rather than just undertake a study reviewing the data retrospectively, that propensity score matching has actually been used here to try really and improve the quality of the analysis. I was maybe going to start off by asking you to just consider, do you think that there might be any specific weaknesses to using propensity score analysis in this particular study? So that's just a general observation about the analysis of databases. There are actually really two studies here. You're attempting to compare open and laparoscopic approaches and are clearly demonstrating a benefit in the laparoscopic approach. But you're really undertaking a very detailed analysis looking at anterolateral and posterior superior laparoscopic liver resections. I guess the question there is why? Because obviously, if a tumour is in a part of the liver, we're kind of committed to taking that bit of the liver out. So I'm kind of intrigued to know how we actually would now use the data, the results that you have got from this really sophisticated analysis and translate that into a change in practice. So in your own centre, how are you actually now using these results going forward prospectively? What are you actually looking at, and how are you modifying your surgical approach? And I'm sure that there will be other questions from the floor. You've made a number of general observations and conclusions, some of which actually I don't think are necessarily supported by data that you have presented here. You've actually indicated that training programs should aim to develop proficiency to allow the expansion of minimally invasive programs. But have you actually really looked here at training? Do you have actually any data now in this extensive database that allows you to look at increasing experience of the senior surgeons, and were any of these procedures actually undertaken by training surgeons? Has that impacted in any way? Because clearly the two types of laparoscopic liver resection that you're analysing here, might be considered to have different degrees of complexity. I very much enjoyed your presentation. I'm grateful to you for having the opportunity to look at the manuscript that's going to be submitted to HPB as part of this meeting. Disappointing that others actually have decided to drop out of the best of the best, but we should certainly be supporting presentations such as this and giving the opportunity for publication in the journal. So thank you very much, Chairman. Thank you, Federica.
Thank you, Professor Gardner, for giving me the opportunity to clarify some crucial points of this study. I think that the use and the implementation of the propensity score in this study specifically is much important and gives strength to the results, since it is inevitable in clinical practice, unless we conduct a proper randomized study, that there is a selection bias when we allocate patients to the treatment, to the kind of treatment that we want. Of course, there was two different kind of populations between laparoscopic and open patients in each cohort of anterolateral and posterior superior. And the propensity score matching such conducted allowed us to reduce the difference and to compare for this study populations that are comparable for many parameters that are used in the main acknowledged difficulty scores for complexity, and so to develop and produce results that are more pure possible, especially in this era where the randomization to patients, we know that it's difficult. Well, concerning the impact that this study is going to have on our clinical practice, we actually have completed as a center our learning curve for resection, the most easy and the most difficult, but we strongly believe in the potential of this approach, and I think that we must recognize that laparoscopy, the advent of laparoscopy in the hepatobiliary surgery is inevitable, especially for some kind of procedure. The temptation could be to stop and to allow patients to have the better results when the easiest resection are easily accomplishable. But we think that with the results there is there should be a sort of effort more toward the implementation also for more complex procedures, and we believe that in the future with young surgeons the implementation of laparoscopy could be also in this toward these difficult procedures. We don't have specific data on this study supporting this, but it would be interesting to analyze some data more to address specifically this issue.
Thank you.
Thank you, both of you, for your nice presentation and nice discussion. Thank you so much. Let's move on to next paper. Okay, thank you.